Right. So, can you see the picture clearly? I think we need to switch off the light, please. So, these two pictures, these are two different patients. And yes, thank you. Thanks a lot. Two patients. If somebody can tell me who do you think is a success patient here? So, the four pictures on the left is one patient. The two pictures on the right is another patient. So, who do you think is a success patient? So, we really need to know what is the definition of success when it comes to bariatric surgery, because a success definition from a surgeon's point of view might be different, and from a patient's point of view might be completely different. So, in this patient on the left, Anna Furness, she had a duodenal switch surgery and she had severe night blindness. She was not working for 1 year because of several complications after the bariatric surgery. But later on she picked up and she went into that mode of getting, with the adaptations that were required in terms of nutritional and metabolic management. And she says her duodenal switch surgery was the best decision of her life. Second patient, Janeth, she did a sleeve gastrectomy and our surgeons, and then she had a duodenal switch surgery. She was struggling with her vitamin and mineral intake because they were huge number, and she says this was a mistake. But you can see clearly the outside appearance, both of them look like success stories, but one is a success from a patient's point of view and a surgeon's and the MDT point of view, and second was a failure from a patient's point of view. So, it's very important to have a definition of what is success. If a patient gets a surgery, and we all know, so as a team we all know bariatric surgeries this is a treatment for diabetes. Diabetes gets resolved within hours, 100, 200 units of insulin, there is no requirement for insulin, blood pressure medications go, sleep apnea gets treated. But if a person after the surgery starts getting these avoidable, I want to reinforce these are avoidable medical and surgical complications: fractures, night blindness, tooth loss, depression, alopecia, severe alopecia, blood transfusions, chronic stomatitis, glossitis, subacute combined degeneration of spinal cord, and to the extent that if patients are being wheelchair bound, is that a quality of life? But again, I want to reinforce these are avoidable. And you all who are assembled here from different parts of the UK and possibly outside, the moral and professional duty lies on all of you. See, we all have to understand the surgeons do a highly skilled job, they do a perfect surgery, but what is important, are you selecting the patients carefully? Are you pre-optimizing these patients that the surgeons receive a person who is in the best state, that they have the best post-operative clinical outcomes? So, the onus of this is more on the other members of the bariatric MDT than the surgeons. Surgeons have their surgical expertise and they do their job. So, most important aspect is selection of suitable patients who engage well, because it's not just you are doing a fascinating job, but if the patient is not engaging, what do you do? So, it's very important to have an engaging patient. And preoperative optimization. So, if a patient is not full, starts from an empty vessel, if the body is empty in terms of lot of nutritional and metabolic deficiencies, a surgery is given which is malabsorptive and restrictive, it's criminal. So, we have to really work hard to optimize patients. And yes, we work in an NHS environment where things are limited, GPs have got limited resources, but we have to do what we have. We have to deal with everything that we are given. So, we have to work at the best, and preoperative optimization, I think the first two steps, if they are done very well, the third will just follow, easy. So, what are the important deterrents for robust patient engagement with the MDT? Life history and lifestyle. I'm sure we can't document everything in our notes, but most of you will say, who have talked closely with patients, psychologists, dietitians, nurses, 70 to 75% of patients will have a history of childhood sexual abuse, domestic violence. Everybody has a life history, and the lifestyle is dependent on the life history. So, if you connect with patients and actually go into the core, you can actually make them do all the changes that are required. Other comorbidities, they limit a patient's capacity to engage with the lifestyle advice, physiotherapist advice, psychological adaptations. So, seriously, it's as AHP, it's so important that you get the right patient, figure out what the problem is, and then they will engage well and take your advice. Your golden advice, they will take it only if they have the capacity. So, if Jen, our physiotherapist, is giving the advice to walk and lose 5% weight, if she doesn't have the reserves, if she is anemic, if she has vitamin D deficiency, if she has depression, she has pins and needles, how can you expect 3 to 5% weight loss preoperatively if the patient has got medical issues? So they have to be correctly, timely diagnosed and managed, and then go with the advice. Something which I feel personally very strongly, sleep quality. Again, a person who's not sleeping well in terms of quality and quantity, that's a zombie. He or she might be sitting in a chair and you might be giving a lot of advice, but it's not going there. That person has zoned out. So I'll just touch a little bit about sleep. People who have chronic sleep deprivation, so we know that they have increased calorie intake, they prefer calorie dense and high glycemic index foods, and they decrease energy expenditure. People who do not sleep well, their memory is compromised. They have poor cognitive functions and decision making capacity. So a person who is not able to sleep well for any reason, your advice might be just going over the head and you will not achieve the outcomes, preoperative outcomes which are required. When you are sleeping, your stress hormone is lowest. At 12 o'clock in the night, the stress hormone is lowest in the patient. If a patient is doing night shift or not sleeping well, has a noisy environment like a little child or a snoring partner, or the patient is snoring himself or herself, they are like zombie in the morning, and there is increased risk of cardiovascular risk, angina, diabetes, and heart attack. And very important, sleep, I'll show you. So these are just complex pathways. I've just put this diagram to show that there are very complex pathways which determine a person's ability to be rejuvenated in the morning, to be rejuvenated and have the capacity to make timely decisions. So it's very important that a person should be sleeping well. And this is just a diagram to show that people who are not sleeping well, they have got compromised metabolic and nutritional status. They have got insulin resistance. So if an awake person sleeps, if a person sleeps for 8 hours, which is the required for an adult person, they drift from stage 1, 2, 3, 4, and every 90 minutes, this is this golden period of rapid eye movement sleep when the muscles go into atonia. Your cardiovascular risk comes down, your growth hormone increases, testosterone is lowest, and vitamin D metabolism is happening, and even on cellular level, genetic level, there are micro repairs happening on the DNA, which in simple terms is decreases risk of cancers. So sleep is most important, even if you can see biochemical changes, so many biochemical changes happening in patients who are sleeping well or not sleeping well. So it's very important if people are drifting just into the initial 4 stages, and never reaching this golden period, because say there was a noise on the road and person woke up while he was shifting into the deep sleep, then he goes back again from starting from the phase 1. So they constantly remain in this stage, and this is, I will straightforward say, if somebody is in this stage, they will die early. There is enough medical evidence to say if people have compromised sleep quality and quantity, they are biochemically, metabolically, nutritionally high risk, and they will die early. So sleep deprivation, we know there is decreased leptin, increased ghrelin, which increases hunger, obesity, increased opportunity to eat, obesity, altered thermoregulation, increased fatigue. Again, the dietitians and physiotherapists and psychologists, if a person is sleep deprived, your advice is less likely to permeate inside that patient. So address the sleep, and you will have a patient who will improve in metabolic status and will engage well with all the advice you are giving. Very important, but yes, that needs a little deeper dialogue with the patient. So we have seen all these diagrams several times. Just to reinforce, from mouth to anus, depending on the site of the surgery, whichever component is compromised, it depends on the surgery. So gastric bypass, sleeve gastrectomy, mini gastric bypass, and duodenal switch. In Homerton, we are lucky that we have a lot of very skilled surgeons. So I have been exposed, and my team, we have been exposed to all different surgeries, large number, and that has been very helpful in our understanding and evolution. So I'll quickly come to the cases. This is 39-year-old female who had diabetes, hypertension, severe obstructive sleep apnea, and she underwent duodenal switch 4 years ago. So after the duodenal switch surgery, the medical comorbidities resolved, but she was lost to follow up for 2 years, and she had 7 teeth loss, and 2 tibial fractures during this period. So if you look at the blood test results, you can see there is anemia from the full blood count, ferritin is low, vitamin D is low with a high PTH, so that suggests secondary hyperparathyroidism, there is increased bone resorption, and bone alkaline phosphatase is an isoenzyme of alkaline phosphatase. Sometimes you might do a liver function test and you see high alkaline phosphatase and you worry, is this liver problem? But actually it's not because of nutrition or liver problem, it's because the bone isoenzyme is raised, because PTH, when you have low vitamin D, PTH is secreted from the parathyroid gland to take away calcium from the bones to normalize the calcium level, and this is done through alkaline phosphatase isoenzyme. So this suggests this was a high risk patient, and if this patient is like perimenopausal, you know this is a therapy for fractures. This is like a sure shot recipe for fractures and osteoporosis with this picture of metabolism. This patient also had a normal B12, and this I have been saying in my different talks which I do in BOMs and everywhere. More and more labs will be doing this, should be doing this. Vitamin B12, a range of 200 to 1000 is a very wide range, recognized nationally and internationally by hematologists, and it can look normal, but if you see the active B12, which is the active moiety of B12, which works on the cellular receptors, this is low. And we also do methylmalonic acid, which is a functional marker of B12 deficiency. So in essence, you can have a normal innocuous looking B12, but the person might be severely B12 deficient, which again says can give you anemia, depression, subacute combined degeneration of spinal cord. When I see such a picture, if I am in the MDT or my dietitian and nurses colleague, they highlight it to the team, this patient should not be given a gastric bypass surgery if till you have corrected all the B12 deficiency, because again bariatric gastric bypass surgery and sleeve gastrectomy is you are creating a patient with pernicious anemia. So if somebody is already low and you give a high risk surgery, again that will not stand anywhere in the court of law if you have bypassed this. The results show it was low and you still gave a surgery which was a high risk. And there was a talk in the surgeons main symposium where they were discussing about medical legal cases. So as clinicians and responsible clinicians, we have to be really careful what you are suggesting for a patient. So high risk of B12 deficiency, I am sure this is a common slide a lot of you have seen, and what here I want to highlight that patients on folate supplements. So if you have got a patient with folate deficiency, please don't start throwing high doses of folic acid on a patient, because this patient might have a very low B12, active B12, which you might miss. And if you give folic acid to a patient who has got functional B12 deficiency, that person, I have seen actually now 4 patients who had subacute combined degeneration of spinal cord, and they can become wheelchair bound, they can have permanent disability. So folic acid should not be given unless and until you have excluded B12 deficiency, especially pregnant females, because they will not even tell you. They will start buying folic acid from Tesco, Sainsbury and taking 4 or 5 tablets together because they just want to bring up their folic acid because of the neurological problems with the fetus. So very important, we have to be careful. And this is just a slide to show you that B12 is required for conversion of methylmalonic acid to succinyl-CoA. And so if you have a low B12 which reflects as high MMA level in the blood, what it shows actually that from 1 molecule of glucose, human beings eat around 2000 kilocalories per day, out of that 50% is carbohydrate. So 1 molecule of glucose gives 32 molecules of ATP, and that is only possible if this cycle completes. But if this cycle is not completing because of B12 deficiency, the person might be eating but not generating ATP. So each and every cell is stretched, neurons are stretched, bone marrow synthesis, so RBCs, WBCs are stretched, glossitis, cardiomyopathy, and problems with fertility and menstrual periods. So actually B12 deficiency is something that affects each and every cell, right. So this patient had severe vitamin D deficiency with secondary hyperparathyroidism, high bone turnover, and coexisting iron and B12 deficiency. They caused compromise with the dentition as well because the gum health was poor. So each and every cells require the growth factors of iron and B12. So this patient, the dentition loss was also, so I talked to the dentist and we worked together, and that's how it's not just one thing, it's a constellation of different things causing a combined picture. This patient was aggressively treated with injections and B12 injections, and then after that she improved and she is fine. But yes, she understood the importance that all patients have to be they have to be regularly followed up, and they cannot be just lost to follow up, because GPs do not know much yet. Although there are guidelines for GPs, but still you get that feedback that they do not know much and they want patients to be seen as in a specialist center. So we have to always try and empower our patients that they know they have to be monitored every 4 months or 5 months depending on their state. This is a case, copper deficiency. I don't know how many of you have heard this before. Please raise your hand, because I will, okay, 1, 2, 3. Okay, so shall I go over this? Okay, this is again, so this was a very remarkable case. We had this patient who came to Homerton. She was operated elsewhere, and she was inpatient in 2 different hospitals for 16 months. She was being treated for Wernicke's encephalopathy. She was wheelchair bound for 3 years, and she was referred here. She had all these features suggestive of neurological implications, and when we did the blood test, this patient had a very low carrier protein ceruloplasmin. MMA was elevated, suggesting severe functional B12 deficiency, but not shown on the B12 level. So you see, abnormal B12 can be seriously misguiding. And vitamin D was normal. Then we did further trace metals. So copper was very low, and thiamine was normal, obviously, because this patient was being treated with thiamine but still the patient was very symptomatic. And copper is required for iron metabolism, and copper is also required for your nerves. So this patient had dual problem. She had very low B12, she had very low copper. So these are trophic factors for the nerves, and that actually led to this condition where she had foot drop, she was wheelchair bound, didn't walk for 3 years. And then some of the people are here who looked after this patient at Homerton. And so all these were diagnosed, and we treated her aggressively with copper IV infusions and high dose vitamins, and she had rigorous dietitian, nurses and physiotherapist support. And actually the best part was that she had a diagnosis of borderline personality disorder for 3-4 years. And actually she's an absolutely normal patient. She got treated for all these deficiencies, and this is an old slide. The diagnosis was revoked because she was never a borderline personality disorder. And she walked in the hospital after 1.5 months. She walked on her feet now, and she initially started with crutches, and now she walks, and actually she regularly comes, and she even got the Slimming World Award in last 6 months. So imagine a person who was just waiting to die. She was in a nursing home. Now she lives in an independent house by herself. Right, so another one's 45-year-old male with BMI of 36. Now this is a preoperative optimization case. I don't think anybody has seen this one before. So this patient had a history of kidney stones and sarcoidosis in spontaneous resolution, and had preoperative bariatric assessment with severe vitamin D deficiency. So yes, we go guns blazing for optimizing patients, but we have to also be careful of the complications which can happen in patients if you are aggressively treating patients. So this is a classical example. So this patient was treated with high vitamin D doses and had a very high calcium, very high phosphate and creatinine. So with this example I'm trying to show you that with very high vitamin D intake, if there are any other contributory factors. So the catch here was that this patient had sarcoidosis, which was in resolution. Now sarcoidosis again is a condition where there are lesions in the lung, in granulomas, which work in a way that they convert 25 hydroxyvitamin D, which is the oral dose, into 125, which is the more active form, and it increases more calcium, and it causes bone resorption. So in a sense, sarcoidosis can precipitate patients to have hypercalcemia if they are given high vitamin D doses. And this patient had a creatinine of 52. So creatinine is a marker of renal function. Normally you might have seen in the lab there is a AKI alert which triggers after a range, but usually the labs have a system that whenever there is a 50% increase, that suggests that your renal function is deteriorating. So as per the reference range, this level was not high, this was within normal, but if you see, the jump was more than 50%. So this patient, a high calcium or hypercalcemia driven by excess vitamin D plus sarcoidosis, gave acute kidney injury to this patient. So this was a normal looking person being prepared for bariatric surgery, landed up with a AKI just because he was just on the protocol for vitamin D correction. So ACE, which is a marker for sarcoidosis, that was normal, but 1,5-dihydroxyvitamin D was done, which was very high, and that explained. So this patient had to be admitted in the hospital, had to have intensive hydration, the treatment for hypercalcemia, and also he had other contributory factors which cause hypercalcemia. So when you are assessing patients, drug history is very important. Like everybody, all of us as clinicians, we are taught take a intense drug history. So this patient was on thiazide diuretic. So in our team, we are very pro. We know, all my teammates can vouch that you have to ask if there is a history of kidney stone. What are the drugs patient is on? So because this patient was a kidney stone patient, this patient was on thiazide diuretics. Thiazide diuretics are given because they decrease the calcium clearance into the urine, but it leads to building of calcium level in the blood. So this patient had high vitamin D, sarcoidosis, thiazide diuretic which predisposed to hypercalcemia, and plus this patient was also on low oxalate and high calcium diet. Again, so there were too many factors which contributed to hypercalcemia. So a diagnosis of sarcoidosis was made, immediate cessation of vitamin D and everything that was precipitating, and symptoms gradually resolved after 3 days of admission in the hospital, and bariatric surgery was deferred to be considered with the help with the relevant specialists around whenever he becomes suitable for that. So one thing, a message from here is EGFR, creatinine. Whenever you are reviewing the results, if you see a huge jump in EGFR, please talk to your colleagues who can comment, a chemical pathologist, your bariatric physician, surgeons, whoever you wish. Yeah. So another case, this is a 53-year-old Asian lady with a BMI of 43 and presented to A&E with palpitations and tightness in chest. This patient had a sleeve gastrectomy, 28 days, and lost 4 kg since surgery. So this patient, like I said, it's very important to have a detailed history about all comorbidities and all the drug history, because if you are not doing it, you might be missing something relevant which might create complications later. So this is not a very well known phenomenon, but we experienced this with one of our patients. So this patient was on 200 micrograms of thyroxine and had other issues. Then because she presented to A&E with palpitations, she had no history of any cardiovascular disease before. She was all clear for the surgery, pre-anesthetic checkup was fine, and suddenly this happened. So when we did her thyroid function test, her troponin was normal. So on the same dose, she was euthyroid, normal thyroid on that particular dose, but suddenly after surgery, she became severely hyperthyroid. And when you are hyperthyroid, it's over metabolism. So hyperthyroidism give you palpitations, and obviously she had some low cardiac reserves that she started having some ischemic symptoms, and she started having angina. So what happens, what is relevant here, that bariatric surgery, especially sleeve gastrectomy and duodenal switch, it alters the pharmacometabolism of thyroxine. So it's very important, and from that time we have a policy that after 3 weeks, if a patient is on thyroxine, after 3 weeks we do a repeat thyroid function test, because in most of the cases you have to reduce the dose of thyroxine. So if you rely on, so we can't leave this to the GPs, we can't leave it to the endocrinologists, because as a bariatric MDT, we know this fact that after sleeve gastrectomy, suddenly a normal dose of thyroxine will become a toxic dose. So it's our professional and moral duty to explain to other professional colleagues who can monitor this. It's very important to pass on this message, and probably in your units, you might want to go back and say that you want to check thyroid function in patients with sleeve gastrectomy after 3 to 4 weeks. So this patient, after the management, had a ECG, showed sinus tachycardia, thyroxine was completely stopped and gradually escalated from a low dose, and then the patient could be maintained on 125 micrograms, which is 75 micrograms lower than the original dose. So the patient didn't lose weight or anything. This is purely altered pharmacokinetics and pharmacometabolism of thyroxine, which gets altered by sleeve gastrectomy. So we have to be really careful. And thyroxine it's not only hard. If you are given too much thyroxine, it causes more bone resorption. Person is more prone to fractures. So we have to be really careful with thyroxine as well. So this was sleeve gastrectomy and duodenal switch. Another patient with duodenal switch surgery 8 years back, and sometimes we get this impression that duodenal switch surgery is quite aggressive, but it is for those patients who had a BMI of 60, who accumulated that weight over 30 years. They need that weight loss to resolve, not only resolve diabetes, hypertension, but also the cardiovascular risk quickly. So yes, these patients, 90% of our patients, 93% of our patients do very well, but they need very rigorous follow-up, and if they miss, then they'll end up in complications. So this patient had an unprovoked pulmonary embolism and was on warfarin, and she was traveling. So she was traveling a lot. She was, she lost weight and she was happy, moving around, what she could not do for many years before. And then she landed up with extensive hemorrhage, spontaneous hemorrhages, and her INR was quite high. So we measured the vitamin K. So one thing I want to highlight, you might not be seeing a lot of duodenal switch surgery patients in your units, but mini gastric bypass, which sounds very innocuous, we have a lot of mini gastric bypass surgery patients, and our surgeons, they are doing more and more mini gastric bypass now. It is also not that innocuous. It is, I have seen patients with a very similar nutritional profile as duodenal switch. So fat soluble vitamin deficiencies, A, D, E, K, I'm seeing them in mini gastric bypass as well, and some of them are requiring trace metal infusions, which seems, because it sounds mini gastric bypass, but it's not that innocuous. In my experience, our team experience, in some cases it is like the most aggressive one, duodenal switch. So this patient had a high vitamin K, and PIVKA, again, it's a functional marker of vitamin K deficiency. So if there is a vitamin K is low, a precursor molecule accumulates in the blood, which is called PIVKA2, and this patient had elevated PIVKA as well. And so this patient was treated with vitamin K, initially injection and then oral tablets, and then repeat vitamin K level was fine, and gradually, actually this case also gave me the opportunity to talk to the anticoagulation team, because again, one thing you will see in NHS, we all try to do our best, but because of the resources, we are all stretched. Communication sometimes lapses. So it's very important to talk to your anticoagulation teams. If you have got high risk patients and you see bruising, you have to get in touch with the anticoagulation team and talk to them, because they give advice about not to eat certain foods because they have got vitamin K, and you give them some advice to eat or not eat food. So sometimes that gap of communication can really trouble the patient. So I discussed with the anticoagulation team, and now we try to do things simultaneously so that they get one centered advice, because most importantly you have to avoid any fluctuations in vitamin K, and hemorrhages is not just subcutaneous hemorrhages, the hemorrhages can be in the brain as well and can be fatal. So please remember, it's not just the bruises which are visible here, it could be in the brain as well. This is a Roux-en-Y surgery patient who started with the BMI of 44, had resolution of all the comorbidities for which bariatric surgeries are given, and started having recurrent renal colics. This actually highlights to me, I think in the UK we still try to do a lot as preoperative optimization, but I am seeing a lot of patients, especially as part of hospital, health tourism coming from Turkey, from India, and it is shocking. Sometimes you see some patients have been lost to follow up for 7 years, and they say they had kidney stones three times. Their life is compromised, they are with stents. It's purely because something has not been done properly and they were not given proper advice. So these patients, this particular patient had calcium oxalate kidney stone, and this patient was on very high doses of AdCal3. I have been reinforcing this for a long time, that AdCal3 is high concentration of calcium. It has got carbonate and it can give extensive kidney stones, and that's why we have changed our policy. We don't prescribe AdCal-D3 to our bariatric surgery patients at Homerton. They have to take calcium citrate, and they actually have to buy it themselves because NHS doesn't provide calcium citrate. So very important, calcium carbonate has got high risk of kidney stones, and as a general national, so yes, we had dialogue with the BOMS team and the nutritional guidelines, and I think I have to rely on leaders like Yitka and Mary O'Kane, who are making all these changes on research level. Yitka and Mary O'Kane as the dietitian lead, and other national and international leaders. We have to get this message across, that something that is harmful, we know it gives risk. Even the BNF says AdCal-D3 should not be given to patients who have got high risk of kidney stones. Now bariatric surgery is actually a milieu where you are creating a risk of kidney stones. Bariatric surgery patients absorb more oxalate, the stone forming element, and if you are giving AdCal-D3, it combines and you are actually creating a recipe for kidney stones. And you will see it. I have seen at least 15 patients now who had been, and because these are the national guidelines, then they need to change. So again, Yitka and Mary and other, Tony, yes, we have to work on this. So this patient had very high calcium in the urine. That's a recipe for kidney stone. Very high oxalate, so calcium and oxalate combined form calcium oxalate stone. And this is what this patient had and many patients have. And citrate is an inhibitor of kidney stones. Citrate is an inhibitor of calcium oxalate kidney stones, so that citrate was less. So this patient had all the positive and negative factors. So we stopped AdCal and calcium rich diet. It's a paradox. You might think if patient had calcium containing kidney stone, they should not be given high calcium in the diet. But actually the paradox is calcium stone risk patient should have a high calcium in the diet, but not in form of oral supplementation as calcium supplements, because that is a positive factor. So high calcium in the diet and water intake, most important. A simple message to everyone saying saying that urine should not be yellow, urine should not be smelly. That's an indicator that you are not dehydrated. All these patients, bariatric surgery patients, open their bowel ranging from 6 to 12. So they are losing a lot of water. If you are not reinforcing to them that they have to drink water and what are the signs they can manifest when they are dehydrated, they are becoming prone for kidney stones. And we have seen patients lost weight but coming for surgeries for their kidney stones, which doesn't help. And like I said, these are all avoidable complications. Bariatric surgery are very useful. They should, more and more people should get it, but we as a bariatric MDT team have to do everything to prevent avoidable medical and surgical complications. Sorry, have I got time or have you got more to go? I think this is the last one. Okay, this is a simple one, anemia. So all of you see anemia. This is a very straightforward case where you have a hemoglobin of 70, MCV, MCH, so macrocytosis. Macrocytes are because of B12 and folic acid deficiency. So this is a simple straightforward case. You can just supplement the patient with B12, write to the GP and they will do it. So MCV, do I need to go on this or you all, you know? Okay. So MCV, mean corpuscular volume. Anytime when the MCV and MCH is high, that shows that the RBC cell size is big. And RBC cell size is big when B12 and folic acid deficiency is there. When the RBC and the MCV and MCH is low, we know it's microcytosis, which is because of iron deficiency anemia. So, but you can see both pictures. So actually the clue here is RDW. If you have never noticed, it's called red cell distribution width. The larger the RDW, you know there are two population of cells. There might be microcytes because of iron deficiency, there might be macrocytes because of B12 and folic acid deficiency. And again, B12, you might think B12 level is 300 normal, but actually the active B12 might be low and MMA might be high. So you have to really be careful, and the easier sign is that if the B12 level is somewhere like 800, 900, you can be assured that B12 level will be normal. Because we have seen bariatric surgery patients with B12 level of 200 to 550 with severe deficiency, but the level is normal. So yes, labs are picking up on this. So here what I want to show, these are two cases where you have anemia, RBC count is low, which you see in iron deficiency anemia, and B12, packed cell volume is low, MCV and MCH are very low. So these are microcytes, small cells. So again, iron deficiency. And if you see the profile here, iron saturation is low, fine, everything is pointing towards iron deficiency anemia. But here transferrin, so when you have iron deficiency anemia, as a compensatory response, transferrin should go up. In this patient, this has gone up, but this patient, it has not gone up. So it's confusing. Is it iron deficiency anemia or not? If you see here, this patient had an albumin of 35 and this patient had an albumin of 16. So albumin is a protein, is secreted by liver. Transferrin again is a protein which is synthesized by liver. So in a patient who has got hypoalbuminemia, the message is you can't rely on the iron profile, because this patient is iron deficient, but it's not reflecting in the iron profile. And just to compare these three, last case, this patient again has got a low hemoglobin of 90, and MCV, MCH are microcytic hypochromic, iron profile is normal, and has an albumin of 36. So do you treat this patient to bring up the hemoglobin before the surgery or not? Any answers? Will you treat this hemoglobin with this iron profile or not? So yes, we need to figure out more. So this patient, last patient, was a beta thalassemia trait. So in this patient, you have to actually do a hemoglobin electrophoresis. In beta thalassemia trait, you will have patients who will have microcytic hypochromic and their hemoglobin will be always low. They can have even coexisting iron deficiency anemia, but you have to rule out. You have to. So this patient had beta thalassemia trait, and if the iron profile was low, you would treat this patient with iron. But some patients might be getting iron transfusion for anything. So you have to be really careful that you treat based on all the features, and if the picture is not clear, hemoglobin electrophoresis might be another thing to add, or you can actually talk to your hematologist to get advice, because iron, it can be toxic, and you will realize some patients, you ask them to take iron and they are so desperate to have the surgery, they will just overdose themselves, and when actually they don't need it. So it's really important to see a picture, interpret, and if you are struggling, take advice from your team and even hematologist if required. So these are some guidelines in which we have worked, and it actually even became a nice quality standard. So there have been some information on this, but this is also, the BOMS guidelines are also due to be updated. The last one were done in 2014. So it will be updated soon, sometime 2020 in the beginning, and I'm sure we will have more up-to-date information, especially around trace metal infusions and everything. Yeah. So see, again, the message which I want to say is bariatric surgeons do a fascinating job because it saves lives. It's life-altering and life-saving. But as a team, we have to make sure that we identify these things and avoid the medical complications, and we can only do it as a team. And I have even talked to the medical curriculum organizers, because junior doctors and there is lack of awareness of bariatric surgery and the altered anatomy, biochemistry and physiology. So we all need to work together to empower patients and other clinical colleagues so that we can do the best. Thank you so much, and I'm really grateful to you all, my hospital CEO, Mr. Agrawal, and Dr. Suro. I can only say that, the work we do, I think we do a pretty decent job here, and it's because of the team and our medical and operational leaders. They provide us that support, otherwise it's impossible to do the work that we try to do. So thank you very much, everyone.